Okay, so we're going to go through the contemporary study for OCD, which is Masellis et al. 2003. This looks at the quality of life in OCD, looking at the obsessions, compulsions and comorbidity with various aspects of depression that can be found. You will need your A3 contemporary study sheet to complete the information about the study's title, aims, procedures, results and conclusions, and then on the back you will be completing the evaluation points. So before we get started, a couple of key points for you to pick out in terms of wider use of the study by Masellis. So first of all, you've got the links to the medical model of OCD. It very much refers to OCD as an illness, and you can use this within your understanding of different types of research into mental health, how people view mental health and the different aspects of understanding. You can also refer to the standardised measures that we use to gather the data. They use an awful lot of self-reporting data, and if you think back to social psychology, the strengths and weaknesses of using self-reported data, particularly questionnaires. You can also relate the content of this back to your content on validity and reliability of diagnosis. They use standardised questionnaires that have been tested for both reliability and validity multiple times, so you can use these as examples when you talk about reliability and validity in terms of diagnosis, and also when you are evaluating the study itself. There is also various pieces of evidence included in the study. If you have a look at the journal article, you can pick out some of these main features in the introductory section. You can use this evidence when you are talking about OCD and explanations of OCD, in particular the cognitive explanations, as well as when you are talking about the study itself, the nature of the study, and whether the study is valid or generalisable. So at this point, you are going to pause the video recording. I want you to have a look at the supporting research that talks about why Masellis et al. Conducted their study in the first place, what triggered their interest in this particular field. And I want you to make a note next to that evidence where you can use that backwards to support explanations of OCD and also criticise explanations of OCD. So pause the video, take about 10 minutes to have a look through the study itself, the supporting ideas, and make some additional notes. Okay, so for the aims of Masellis, if you can make a note of these, the first aim was to look at the quality of life for those patients who had been diagnosed with OCD, mainly looking at the impact of obsessions, compulsions and depression on those individuals. Second aim is to see if quality of life ratings would be affected by how severe the obsessions and compulsions were. So the overall idea of this was to actually sort of step away a little bit from just rating the severity of obsessions and compulsions, and looking more at what the impact of those obsessions and compulsions were for people who had been diagnosed with OCD, and how it affected their day-to-day living and how they judged their quality of life. So, you know, there are elements of OCD that people manage to live with and don't feel that their quality of life is impinged too much. However, there are also other people whose quality of life and ability to function on a day-to-day basis is affected quite severely by their obsessions and compulsions. So the idea was to sort of have a look at the individuals and just see whether there was any form of connection between severity of obsessions and or severity of compulsions and how people rated their day-to-day experiences. Okay, so for your sample, in total, Masellis looked at 43 patients, and it was quite a broad age range between 18 and 65 years old. They'd all been diagnosed with OCD using the DSM-4, and they were all based out of an anxiety disorders clinic in Canada. The gender split was fairly fair and representative, so 18 males and 25 females. And in terms of their life and their day-to-day life and lifestyle, 25 were single, 16 were married or cohabiting with their partner, 2 were either separated, divorced or widowed, with the average age overall for the sample being 34.9 years. So within their procedure, Masellis used a number of measures to measure the severity of obsessions and compulsive behaviours. The first of which is the Yale-Brown Obsessive Compulsive Scale, which you can refer to as Y-Box. The Y-Box has 10 items, so 10 questions, and is a standardised scale for assessing severity. It uses a 5-point Likert scale, so each question has a 5-point scale ranging from 0, which represents no symptoms, to 4, which represented severe symptoms. It has been tested for both reliability and validity, and it is found to have high validity and high reliability. So it is a known, accurate and reliable measure of the severity of obsessive compulsive disorder. Again, as we're going through this, think about what we talked about in social when it came to questionnaires. Things like the range from 0 to 4, how useful will that be for differentiating levels of severity? Is a scale from 0 to 4 enough? How might that affect the outcome of the study, and so on? So think about these things ready for your evaluation points. Another measure that was used is the Illness Intrusive Rating Scale, so IRS, and this measures how far symptoms interfere with someone's quality of life. So it uses objective measures and the individual's perceived interference. This questionnaire is structured around 13 domains, so it's sort of like 13 topic areas, and they include things like the severity and the impact and intrusiveness on things like health, a person's financial situation, relationships with their partners, children, friends, and so on, community involvement, so whether they can go out, whether they are members of community groups, socialising, that sort of stuff. Again, it uses a Likert scale, and this is a 7-point scale, so it ranges from scoring whether those symptoms interfere on a scale from 1, not very much, so don't interfere very much, right the way through to 7, which is where the symptoms interfere very much, so quite significantly. The scores across each of the different questions are totaled up at the end, and the total score will come to either 13, which is a minimal intrusion, so not very intrusive at all, right the way up to a 91, which is extreme intrusion. And obviously a person can score anywhere in between 13 and 91, depending on how they rate the different questions and severity within the 13 different domains. So, for example, someone may feel that their OCD affects their relationships quite severely and is very intrusive into relationships, but may not feel that their OCD has an intrusive factor on their financial situation. So overall, across all those different 13 domains, the totals are added up, and it can be from 13 to 91. Again, think about your evaluation points. This is quantitative data. It is objective in terms of Masellis' interpretation, but again, it may well be subjective in terms of the way in which somebody completes a rating scale of intrusion. It's a subjective idea. How intrusive is it into your life? Can be different for different people. So you've got that sort of subjectivity in the way in which people score their own personal circumstances. Another measure is the Beck Depression Inventory. If you remember, this was also used by Berger when he was screening his participants for his replication of Milgram. The Beck Depression Inventory has 21 questions, and each question uses a 4-point scale. So the BDI was used to test the comorbidity of depression with obsessive compulsive disorder. Again, it's self-report data, and it assesses the severity of depression symptoms, and it has been tried and tested and has been found to have high reliability and high validity. So again, you can link this back to your reliability and validity of diagnosis content earlier on in clinical, and you can also link this into the evaluations of the study. If they're using reliable and valid measures of their different variables, therefore they will have high internal construct validity in what they're testing, and they will also have high reliability in the data and the results that they are getting from these measures. Within the procedure and analysis for Masellis, they applied the use of statistical testing to look at the significance of the information that they gathered. So one of the statistical tests was to see if there were any variables that could predict how intrusive OCD was for people. So they looked at the clinical variables, so the severity of the illness, and they also looked at demographic variables, so things related to whether the age of a participant predicted intrusiveness, whether there was a difference between males and females and the prediction of intrusiveness, and things like their marital status and so on. Other analysis included correlational analysis between the BDI, the Y-box test of obsessions, and the Y-box compulsion scores, and they were expecting sort of strong relationships and correlations between the severity of obsession and severity of compulsive behaviour. So the results for Masellis' study: a person's age, the age of the onset for diagnosis of OCD, marital status, gender and educational levels were tested against the amount of intrusion that was felt in terms of the obsessions and compulsions and how much that affected people's quality of life. None of the demographic factors were found to predict levels of intrusion scores for OCD. However, there was a significant positive correlation between compulsion scores and intrusiveness, tested at P 0.01, so at 99% significance. And there was a significant positive correlation between the obsession scores and the level of intrusiveness that was rated by the participants. So overall, the higher the score for obsessions and compulsions, then the higher the participants rated how intrusive that was on their day-to-day life. In addition, Masellis looked at the depression scores and the obsessions and compulsion scores, and they were analysed together. What they found was that a higher score for depression predicted intrusiveness on people's lives. So the higher they scored on the depression scales, the more likely they were to find their OCD symptoms to be intrusive. Equally, the higher obsession severity also predicted intrusiveness. So that is, the more severe the obsessive thought process was, the more people felt it intruded on their quality of life. But what they did interestingly find was that for the compulsive behaviours, there was not an association with intrusiveness. So what it suggests is that it is the obsessive thinking and thought processes that correlate very highly with intrusiveness, but the compulsive behaviours don't get scored quite as highly for intruding on someone's quality of life. So it's more to do with the thoughts and the obsessions than it is to do with the compulsive behaviours. So when they analysed the data around scores for depression, it came about that depression accounted for around 54% of the scores related to how intrusive the OCD was felt to be on quality of life. So the obsession score on the Y box accounted for 39% of intrusiveness on someone's quality of life. Ultimately, this showed that the comorbidity with depression was more likely to be felt as intrusive, although obsessive thought processes were also part of the score, but depression was more significant. And again, this also confirmed the fact that the compulsive behaviours and the compulsive need to do particular habitualistic and routine actions were not the main issue relating to how people felt OCD intruded and decreased their quality of life scores. So overall, depression seems to affect the intrusiveness the most. So if you have OCD with comorbid depression, you are more likely to feel that it is intruding on your quality of life. And next important was the obsessive thought process and obsessive thinking, which came second in affecting your quality of life, with compulsive behaviour not really featuring in any of the main issues. So from the outcome of their study and the findings, Masellis found that severity of obsessions affected how much OCD intruded on someone's life, and the compulsions were less intrusive. Obsessive thoughts and impulses lead to anxiety, as we know when we think back to the cognitive model, whereas the compulsions are strategies to reduce anxiety. So it's not necessarily surprising that people find that it is the thoughts that trigger the anxiety that cause the most intrusion to how well they rate their quality of life. One of the main conclusions, though, that came from Masellis, which you can link to evaluations of cognitive behavioural therapy as a treatment, is that majority of current treatments for OCD tend to try and address the compulsive behaviour more so than they do the obsessive thoughts. And given the findings around the sort of correlations with depression and obsessive thinking being the two most sort of highly rated concerns that patients have, it may be that the way in which OCD is treated needs to shift its focus. So moving away from the current process of treating the compulsive behaviours into a wider process of addressing the obsessive thinking and the thought process behind it. So the conclusion by Masellis is also supported through earlier research by Freeston et al. And they found that 17 to 44% of OCD patients don't actually present with compulsive behaviours. Their behaviours are not systematic, and their obsessive thoughts are dominating their diagnosis of OCD. So again, this backs up the idea of the conclusion that treatment that focuses on compulsive action may not be the most successful form of treatment for someone with obsessive compulsive disorder. And the example of cognitive therapy that focuses on just the obsessive thoughts, changing the thinking and faulty thinking patterns, may be more useful for someone with OCD than something that is cognitive behavioural therapy, where the therapy focuses a little bit on the obsessive thinking, but quite a lot on the behavioural and stopping the behavioural response to those thoughts. Also, because depression is related to the OCD symptoms, Masellis suggests that the treatment of depression should also be a priority when you are looking at treatment programs and plans for interventions with patients with OCD. Okay, so the remainder of this session will look at the evaluations of Masellis. Again, these are summaries of strengths and weaknesses. What I suggest is that you watch and make notes on the evaluation points, and then once you have made notes on those, go back to the structure and separate those out into the detail for assessing things like reliability, validity, grades, and so on. So your first strength is in relation to using a reliable and valid measure for quality of life. You can link this in a couple of different ways, in the sense that we're talking here about reliable and valid scales. They're reliable because they've been used before, and they are valid because they've been checked for accuracy. So that's to do with the content and the questionnaires that were used in the study. As a result, what that means is if you're using a reliable and valid measure, you can link that through to reliable and valid findings and conclusions. So don't muddle here the reliable and valid measures with reliability and validity of the actual study. Another strength you can link back is to your statistical testing. So we're looking at the use of quantitative data that has been objectively tested for significance, using statistical analysis to break it down into whether or not the data is in fact significant. The correlations and the links between the factors and how much they affected quality of life gave strong levels of significance. So this element of the use of quantitative data and the application of statistical testing means that ultimately, when they are drawing their conclusions about the fact that depression is most intrusive, followed by obsessive thinking, and that actually compulsions are less intrusive, they have objective measures and objective tests of these particular variables. So this can then furthermore be applied to suggesting the nature of treatments and the priority of treatments for OCD. So you could split this out, one into reliability and sort of the objective measures, and you can switch also to the application to therapies and treatments for OCD needing a cognitive focus. So all of that process gives strength to the claims of the study. Another strength that you can use to evaluate the study is that the diagnosis of OCD using the DSM-4 was done independently. So all of the patients that were included as participants in the study had been diagnosed independently with a professional clinician and hadn't been diagnosed specifically for the purposes of doing the research. The diagnosis of OCD has been found to be reliable. So it's a reliable diagnostic criteria in the DSM and has shown consistency over time. And overall, this allows credibility to be drawn with regards to conclusions being made about what is intrusive, what is not intrusive, and what type of therapies would benefit patients with OCD the most. Another strength is that there is further existing supporting evidence that there is an impact on people's quality of life from OCD, and it can be felt as very intrusive. Curran et al. In 1966 found that people with OCD were affected quite significantly in their roles in life as well as in social functioning. So OCD didn't just inhibit their sort of day-to-day social functioning in terms of, obsessions and compulsions preventing you getting out of the house or going to certain places, but actually it had an intrusive negative impact on their overall roles in life. So how well they were able to function in relationships, as parents, within friendships and at work and things like that. Further strengths, obviously, the outcomes of Masellis can be applied very well to therapeutic programs. So this can improve the lives of patients with OCD by addressing the actual quality of life factors. So you can shift the focus to obsessions rather than just the compulsive behaviours, which have obviously been found to be less intrusive and less urgent to actually manage because they didn't affect quality of life. It does help provide evidence, going back to CBT, that it would be effective where it focuses on obsessive thoughts, so the cognitive element, as a priority over the behavioural element. It would also suggest that other intervention therapies, so things like exposure therapy, which is purely behavioural, systematic desensitisation, which would be purely behavioural, flooding, which would be purely behavioural, would be less effective because they only focus on the compulsive behavioural responses rather than the thought process that goes on behind OCD compulsions. So again, using CBT with an emphasis on the cognitive element, the faulty thinking, the catastrophizing, the thought action fusion issues, is supported through the findings of Masellis. So moving on to some examples of weaknesses. Generalizability of the results is a bit limited. The 43 patients were all from the same anxiety disorder clinic in Canada. And this may well not represent a wider population of patients with OCD. Not every patient with OCD gets referred to a specific anxiety disorder clinic. Not all national health systems in countries have that sort of set up around anxiety disorder clinics or specialists in that particular field. You can link this to some of the facts from the cultural aspects of mental health. Not everyone would go and seek support, and not every country or culture would offer this kind of support. So the fact that these particular patients had been referred for specialist clinical care may affect whether they are representative or not of those wider members across different cultures and different societies. Equally, it could also mean that the quality of life scores for the sample may be slightly skewed. Patients who do generally get referred to specific intervention clinics like an anxiety disorder clinic are likely to have quite severe OCD. It's likely that they've needed significant intervention and support along the way. So the sample may well represent 43 patients with very severe obsessive compulsive symptoms as opposed to the wider population where OCD symptoms are more of a spectrum. So there could be a lack of population validity within the sample as well. So you've got representativeness and generalizability, but you've also got the issue of population validity as whether they actually tested the people that they need to be testing. Further weaknesses in relation to the sample, you can look at the size of the sample as well. So there were only 43 patients. So you can talk about skewed data for reliability and anomalies. If you've only got 43, it's not going to take an awful lot of anomaly data and unusual scores to skew the results. For example, the results about how intrusive the compulsions were for example. Equally, it's not a reliable number in the sense of it's matched to the population and proportion of people with OCD in society. Approximately one adult in 40, which is around 2.5% of a population, will be diagnosed with OCD on, whatever level that may be on the sort of scale of severity. And so Masellis may not be able to draw particularly strong conclusions, as they only gathered that self-report data from 43 people. So that doesn't really cover a large range, and OCD is diagnosed in a large range of people. And equally, it's obviously small in the sense that you could have quite significant anomalies that will skew those results. So you can split that out into two separate weaknesses. As we mentioned earlier on, obviously all of the data was gathered through rating scales, and it was self-report data. And as we've mentioned in previous studies and in previous topics, self-reporting data is open to subjective interpretation by the participants. It may be objective for the researchers to analyse that data. They don't need to interpret the meaning of a score of 3 or 20, but the participants in the study have an element of subjectivity. If you are trying to self-rate the intrusiveness of your obsessive thinking on your quality of life, for one person, a score of 3 out of 4 for high intrusiveness may represent the same actions and behaviours or thoughts as somebody who scores that as 4 or 1. So ultimately it is quite subjective in terms of the way in which the participants would interpret what the numbers on those rating scales mean. Equally, a second point is participants may show social desirability in their responses. So they may not want to provide genuine answers about how their OCD affects them in terms of their quality of life. It can be felt perhaps as, embarrassing if you admit that actually your quality of life is affected because you have to spend 30 minutes a day cleaning a particular area of the house or checking the locks on a particular door. It can seem silly, it can seem like embarrassing behaviours. So actually the data on the compulsive actions is the one that social desirability is quite likely to have had an impact on the most. So the lack of genuine responses in there because of social desirability would impact on those elements of validity. Because of stigma and stereotyping around mental health, you may find as well that people just downplay the severity of their depression, obsessions and compulsions. So, the scores that come in could actually represent a step lower than how intrusive and how poor their quality of life actually is. The data may also lack reliability and not be a valid representation of how OCD is experienced by each of the participants. Further weaknesses of Masellis' study relate to the cross-sectional nature of the method that they chose to investigate OCD and quality of life. Because it's cross-sectional, it looks at ratings done by each individual based on how they felt at that particular moment and that particular stage in life. So obviously, as you go through the developmental life stages, what you experience at 18 will be different to 30, will be different to 60, and therefore the impact of OCD on your quality of life could differ and change. It could get better or worse over a period of time. So because the symptoms were taken at one moment from people of different age ranges, whilst it does capture the quality of life at that period of time and gives a really good indication of how it does affect people, it does also mean that actually it doesn't give a long-term prognosis. It doesn't track the course of the disorder for any of the patients. And Masellis et al. Actually argue themselves that what is probably needed is a longitudinal study that would be better for those reasons, and would be better able to track how that quality of life experience changes over time. It's worth remembering, obviously cross-sectional research is part of the research methods in clinical psychology, so you can go back and add this information in and add the features of Masellis in as a cross-sectional study example if you are asked to look at the cross-sectional method and its strengths and limitations when we are considering using this method in any sort of clinical investigation. Okay, so that brings you to the end of the sort of more specific strengths and weaknesses that we've gone through. You need to go through the remainder of the Graves points on your study sheet, so considering things like ethics, ethical strengths, any ethical weaknesses, and so on. Fill in the remainder of those strengths and weaknesses points, and then make a plan for an evaluation. So as we know, the largest evaluation question on the clinical section of this paper is up to 20 marks. So what I want you to do is have a go at planning out. Don't write this as an essay, it must be a plan. The AO1 and the AO3 content for something like this, do it in bullet point form or mind map form. Link each AO1 point to a strength or weakness, and then an alternative, so either a counter point, so give the strength and then show evidence of the weakness of the strength, or do the AO1 point with AO3 and AO3 both strengths, or AO3 both weaknesses. Any combination of those would be fine. Have a look back through the notes that you already have in the same way that we did with Rosenhan. So go back to some of the content on reliability and validity. Bring those elements of whether diagnosis is reliable or valid into some of your evaluations. Have a look back at culture and see if there's any relevant points and studies in there. Think about the fact that this is based on an assumption that obsessive thinking can in fact be changed. So have a think about your biological aspects of OCD and whether or not the recommendations for therapy would be of any use if the cause of OCD is a biological brain dysfunction. And also consider whether or not there are better treatments and therapies, whether or not the study is holistic or reductionist, so try and bring in some of those issues and debates. Are they focusing too much on nature or nurture? Have a think about whether or not the study is scientific. Draw on some of the ideas. Again, go back to stuff around self-reported data that we touched on back in year 12 in social psychology. Think about the strengths and weaknesses of using questionnaires, of using rating scales, and of using self-reported data. How would you use those key points to evaluate the specifics of this study? So you've got the ones that I've provided. Finish off the ones on the sheet and think about some of those wider evaluation points that you can bring in. The plan for the essay, you can do it with your notes and with the information in front of you. It's not an unseen plan, so that's totally fine. Should take you approximately 30 minutes to go back over and recall and recap some of the key ideas from earlier in the course.